Hello, everyone, and a very warm welcome to this first joint APHRS-LAHRS Young EP webinar. I am Dr. Kumar Narayanan from Medicava Hospitals, India. I am the present chair of the Young EP Committee of the Asia Pacific Heart Rhythm Society, and it's really my honor and privilege to welcome all of you to this Young EP webinar. The APHRS Young EP Committee has been organizing these Young EP webinars over the last few years with the theme of case-based learning, in which we are looking to present illustrative cases from young EPs and then learn some important concepts in EP through that for the audience. We have found this format to be popular and engaging, and hopefully it has helped young EPs to gain some knowledge and important concepts in electrophysiology. And we have a set of speakers who are going to be presenting some illustrative cases. And to guide the discussion, we have senior chairs, senior electrophysiologists in the field with us. And today it's my special honor and privilege to introduce our two chairs. We have firstly Professor Huinam Park from Korea. He's the Professor of Medicine, Director of Cardiac Intervention and Electrophysiology at the Yonsei University Health System in Korea, and also the current president of the Asia Pacific Heart Rhythm Society. A very warm welcome, Professor Park. And joining him, we have the co-chair from the LAHRS side, Dr. Nestor Lopez Cabanillas. He's from the Adventist Cardiovascular Institute of Buenos Aires, Argentina. He's heading the arrhythmia and pacing service there. And he's also the president-elect of the Latin American Heart Rhythm Society. It's our honor and privilege to welcome you, sir, to this webinar. And today we are going to be focusing on the theme of ventricular arrhythmias and sudden cardiac death. And we have four excellent speakers who are going to be presenting their cases for all of us to learn. We will have 10 minutes for each presentation, followed by about 4 minutes of discussion with the chairs. So I request all speakers to kindly stick to time. And to start it off, we are going to have the first speaker. He's Dr. Muthaiya Subramanian. He's a cardiac electrophysiologist at AIG hospitals in India, and he'll be talking to us about VT ablation in hypertrophic cardiomyopathy. Please go ahead, Dr. Muthaiya.
I hope you can hear me and see my slides, and I thank APHRS for this invitation. So I'll be speaking to you about a case of VT ablation in HCM, and I'll be sharing our experience in these kind of cases towards the end of the presentation. So we'll get straight to the case. This is a 56-year-old male who was in a dilated phase of HCM or end-stage HCM with an EF of 25%. Had a single chamber ICD implanted all the way back in 2011, and presented basically in a VT storm and cardiogenic shock. And this is the ECG he had saved back in 2011. Just to show, I'm going to contrast it with the current ECG, but just to show that there is already back all the way, almost 10 years ago, we can see evidence of fragmented QRS. You're seeing some IVCD pattern, some atrial enlargement. But just to compare how the disease has progressed from 2011 to 2018, you can see the widening of the QRS. You can see that the patient has actually developed some intraatrial delay. If you can see lead 2 and lead 3 and see the P wave morphology. So the disease has progressed, and that is probably one of the reasons why the LV dysfunction and the atrial disease has also worsened as well. So this was the 12-lead ECG at the time of presentation. So this is a left bundle sort of IVCD sort of QRS. QRS duration is around 130, 140 milliseconds, maybe even a little bit more than that. But one thing to note here is that the initial part of the QRS is actually quite sharp in this VT morphology. And it's important to make note of that for the future, for the later part of the presentation. So this was the first time we took this patient for ablation. You can see QRS duration was 182 milliseconds. Baseline HV interval was 61 milliseconds. This was done under general anesthesia with hemodynamic support because of the patient's hemodynamics at that point during the VT. This was an endocardial ablation. We did find, so our approach in these kind of patients is, because of the hemodynamically unstable nature of the VT, is to target the substrate. So this was an entirely endocardial procedure. And at this point, we found some scar, and I'll show the scar map, but a lot of fragmental potentials in the anterior and anteroseptal regions. And this is just to demonstrate that when we were in the scar and we were pacing in the scar, you can see that the stim to the QRS is decrementing, showing that there is some decremental potential within these scars. These are some of the strategies that we use to sort of identify the isthmus site during substrate mapping. But this patient didn't give us much time, so we had to do a quick map. We found the scar areas in the anterior and anteroseptum. It was only an endocardial ablation. We didn't attempt a epicardial ablation at that point in time. Then patient subsequently was, because of the LV dysfunction, patient was upgraded from an ICD to a CRTD, and he did well. He was on a 2 or 3 antiarrhythmics, but remained in NYHA class 2 despite the low ejection fraction, and he actually did well for a couple of years. And I'm sorry, following, I'll just come back to this. So following this CRTD, this was 1 year later following, and this is 1 year later, again, he presented with a VT with cardiogenic shock. So the difference between this VT morphology and the previous VT morphology, if you can see from the beginning of our QRS, from the red line denotes the start of the QRS, what we feel is the start of the QRS. Sometimes in these broad QRS rhythms, it's sometimes hard to identify where the QRS begins. But we can see that one thing is that this QRS is definitely broader. From the beginning to the peak of the R, it looks delayed, possibly suggesting an epicardial exit now compared to what previously, and this was the old VT ECG, where the QRS is quite sharp. So this VT did look something different, and our suspicion here was that it was an epicardial exit that we were dealing with. So this time, again, under general anesthesia, we planned for an epicardial VT ablation. And the idea here was, again, to first take care of this epicardial substrate and then to induce and see the VT, whether the VT was inducible after a substrate modification. So initial mapping, and this is in the LV lateral wall. You can see that we have some late potentials that are outside the QRS on this catheter that the red arrows are pointing. So, and this is just to show that we have a voltage map here on the left in RAO and LAO. And this is a late potential map that was created based on the timing of the late potentials after the QRS. And there is some correlation between the scar and the late potential areas, which we would expect. And these areas were all targeted with ablation. And so once we were done with the substrate, we went ahead and induced VT. This is extras at 500, 350, 310, and 300. And what we are seeing here is another, and now the VT is being induced. And what we can make out here is, as you are pacing and inducing the VT, we are seeing a decrement within the ventricular EGMs denoting scar. But more importantly, we're inducing a VT that starts with a His potential. And what we can see is this is consistent. And you're seeing that I showed you the HV at baseline was 60 milliseconds. Now you're seeing the HV during the tachycardia is 98 milliseconds. And more importantly, you can see that this change in the H interval is actually driving the change in the VV interval. So this was the 12-lead morphology at this point in time. And the other thing is we can see that there was a multipolar catheter across the His here. So you are seeing and I'll show this more clearly in another slide, that the activation on the His is proximal to distal. So proximal, mid, and then distal activates. So again, this VT was hemodynamically unstable. Most of his VTs were unstable. So most of the time we had to convert this with shock. So he didn't give us much time. So a wide complex tachycardia, left bundle or IVCD with a right axis deviation, positive HV interval. Our diagnosis was a bundle branch reentrant VT. But we wanted to, ideally, we would like to entrain these VTs from the RV apex before we make a diagnosis of a bundle branch re-entered VT. So we didn't have that because we couldn't do that because of his unstable nature. So the way that we proved this circuit was he had an ICD. So we went back and looked at some of the ICD electrograms. And what we found is that sometimes when he was delivering the ATP that was being delivered here, you can see that the post-pacing interval after it's being entrained, after the VT was entrained, is only 20 milliseconds from the RV apical lead. So this may provide some evidence that we are able to entrain from this VT from the RV apex. So the His bundle activation was similar in sinus. This is during apacing and ventricular tachycardia. And the only sort of way that this is possible to have a proximal to distal activation during a bundle branch VT, we felt was if you're you would have to have antegrade conduction down the right bundle and retrograde conduction up the left bundle. So this is probably the potential circuit, and this as a counterclockwise bundle branch re-entered VT. So it was ablated at the distal right bundle. No VT was inducible and he's doing well. Actually, now it's almost 2.5 years after follow-up, after this ablation was done. Just going to spend 30 seconds just showing you one or two, and I'm not going to spend too much time on this case. I just like to highlight our experience with VT ablation in HCM. So we do have a lot of patients who come with hypertrophic cardiomyopathy, and we have these patients on follow-up. These are 14 patients that we've recently published where VT ablation was performed. And just to highlight that many of these patients require endo and epi, and that's usually the case because they do have a lot of intramural and epicardial substrate. And surprisingly, 3 patients similar to this, we found 3 patients to have a bundle branch re-entered VT in this HCM cohort. So acute procedural success, we found this in all patients. 3 patients had a recurrence. This is over a mean follow-up of roughly 28 months. But these patients do have progressive LV dysfunction and heart failure. And so this is things to keep in mind. I hope I finished in time, and I will be happy to take some questions. Thank you.
Excellent, Dr. Mutia. Very well presented. And over to the chairs for their comments. Professor Park.
I think it's a beautiful case of bundle branch reentry, but this patient also has a huge scar area because burnout stage of hypertrophic cardiomyopathy. So where did you find a success site of ablation? Can you show it to us?
Sure, sir. So the bundle branch re-entered VT, we ablated at the distal right bundle.
Distal right bundle.
Distal right bundle. I don't have the fluoro of that, but it was ablated at the distal right bundle.
Because this kind of patient has a large scar burden, so if we burn too much, probably it has a risk of aggravation of heart failure, and sometimes the patient cannot recover from the heart failure. I have one patient, eventually I put the LVAD after VT ablation, so we have to be very careful. But if it is you diagnose their bundle branch reentry clearly by the detailed and high density maps, so it was very useful to find out the bundle branch reentry. Actually, the Josephson described the bundle branch reentry is quite common, even almost 15% of non-ischemic cardiomyopathy. But recently we are putting the ICD, so it is not common for us to map the bundle branch reentry. It's a beautiful case. One more thing I would like to comment is that during epicardial mapping and ablation, if your patient is under general anesthesia, you have to be careful for the frank nerve capture. Even though we try to the frank nerve pacing before burn and the anterolateral wall, if the anesthesiologist use a neuromuscular blocker, sometimes it is masked. Even we pace at the frank nerve area, the patient doesn't show any frank nerve capture, so we have to be very careful about that. Okay, thank you.
Great comments, Professor Park. Dr. Lopez Cabanillas.
Just to congratulate the colleague and to point out that it's very important to know everything, how to implant a pacemaker, CRT, how to deal with complex arrhythmias, through the endocardium, the epicardium, and also how to deal with this hemodynamic instability. Something to say maybe is when you do an epicardial approach, sometimes it's good to do a double access, one to ablate and other to deliver a drainage because the irrigation could fill the epicardium. But just excellent case.
Thank you, Dr. Cabanel. There's one question from the audience. How do you identify the distal right bundle? Did you use a EGM or how did you identify it?
It is by, so the one thing to understand is this patient, most of the time he was in an A-paced rhythm. So we go by the sort of by fluoroscopy and also by the EGM of looking at the where you map the His, you get a His area, and then you can subsequently map the right bundle area as well.
You tried to entrainment mapping it there, right? Ablation target site.
So we didn't, because every time we paced this man, he became unstable. So we didn't have much time to entrain or to map this area during VT. So this was more of a anatomical ablation for the distal right bundle based on the EGMs.
Yeah, but I think you showed this excellent tracing from the ICD, where I think again, a very useful learning point whenever an ATP terminates an arrhythmia in an ICD, looking carefully at the tracing at post-pacing intervals, how it terminates. I think it's going to be very valuable to understand, is it an SVT, is it a VT, or what kind of arrhythmia potentially. So that's also, I think, a great learning point. So thank you, Muthaiya, for that excellent case. We'll move on to the second presentation now. It's my pleasure to introduce Dr. Joan Diaz Heredia from Los Cabos General Hospital in Guayaquil, Ecuador. He's also the chair of the APHRS Young EP Committee, and he's going to be talking to us about genetic testing in arrhythmic sudden cardiac death. Dr. Joan, please go ahead. So please unmute yourself, Dr. Joan.
Okay, thank you for the invitation and the presentation of Dr. Kumar. And could you tell me if you could see the presentation, please?
Yes, please go to presentation mode.
Okay, now let's focus on clinical electrophysiology. That's my zone of expertise. So let's talk about usefulness of genetic testing to diagnose arrhythmic sudden death. Okay, I have nothing to declare. And let's talk about this patient. Okay, this is a 21-year-old male who complained of syncope while swimming. He had no relevant diseases reported and no allergies. He was under no medications. Physical examination revealed no remarkable findings. And to note, he had 3 prior syncope episodes, all of them related to swimming. And the first of these episodes was when he was 15 years old. Okay, and very important to note is that all these syncope episodes had no prodromes, and they also had they didn't have also palpitations on any other kind of symptomatology. But a very remarkable find is that he had in his family history 2 uncles who had suffered from sudden death at the age of 20 years one, and the other at the age of 18 years old. Okay, and this is the ECG of the patient, 21 years old patient, and we found a very limited ECG. We found a low heart rate, about 42 beats per minute, and an incomplete right bundle branch block. But there's no other remarkable finding at this point. Okay, I don't know if any of the panelists would like to add any other comment about this ECG. No?
Just click and
Okay.
again, go ahead. Yeah.
It's okay for a person who is 21 years old. Maybe if he had no the episodes, the syncope episodes, maybe we could find this as a normal ECG. And so let's go to risk stratification. What guideline says? Bien, well, according to European guidelines for syncope, we have to focus on 4 elements of the syncope. First of that is about the syncopal event. We have to describe, we have to identify some characteristics that could be of very high risk. In this case, we found that there are 2 important characteristics that show very high risk for this syncope. One of them is that was syncope during exertion, and the other one was that there is family history of sudden cardiac death at a young age. So we are not in a very simple episode of syncope. Actually, we are facing to a really complex episode, and we have to go further into investigations. Past medical history, well, there's no high-risk criteria that we found, and physical examination didn't show any high-risk criteria. ECG show a minor criterion that is asymptomatic mild sinus bradycardia. As you could remember, there were 42 beats per minute. So what could we do now? What could we think about this syncope? It could be a vasovagal syncope, a benign condition, and maybe we don't have to do any other thing. Is that a sinus node dysfunction? And maybe we could plan a cardioneural ablation or a pacemaker implantation. Can we think about a specific channelopathy like long QT syndrome? We could apply Schwartz criteria, and after that, we could start some kind of therapy. Or could we have another condition in mind? Or we're not sure yet. Okay, well, this is what happened when we are dealing with a real case. Okay, we have a condition, we have symptoms, we have signs, and we have to think very careful about what we are going to plan to do. So, well, let's go further, and we plan to do some investigation with the patient. We perform a Holter ECG, and it's very interesting in this Holter ECG that even when the patient, that the patient had a mean heart rate of 38 beats per minute, when we analyze HRV, we didn't find we didn't correlate this with a parasympathetic result. Or if we were facing a parasympathetic episode of syncope, we could expect to have more these levels of parameters higher, and that was something that didn't join with the case. Okay, and we performed exercise stress test, and the patient had a relative reduced chronotropic response, but very important was that the study was finalized because the patient presented by Gemini. Okay, we're going to show this later, at the stage 4 of Bruce protocol. Okay, angio CT, there were no lesions, there were no any vessel lesions, and we didn't consider important to perform a tilt table test because we didn't expect that these were vasovagal syncope. Here you can see the stress test trace. We can see the bigemity. This is a stage 4, as we mentioned before. And here's something important. If we see the ECG, the QT was at a normal level, but if we analyze the Schwartz criteria, we can see that if we use this tool, we can see that we have low heart rate, we have syncope with stress, and we have unexplained sudden cardiac death in people in relative of age younger than 30 years old. So just adding these points, we could get the 3 points that we need to suspect in this pathology. Okay, we couldn't find at this point any corrected QT lower higher than the threshold, but we have this on mind. Okay, now we have more information, we have more things to think, and what can we do at this point? We will perform an EP study, a conduction EP study, an induction EP study. What will we expect to do with these results? A pacemaker implantation if conduction is not good, or an ICD implantation if we could induce some kind of ventricular arrhythmia. We could accept long QT syndrome just by Schwartz criteria without a long QT documented in any ECG or a stress test. Or we could perform genetic testing, focus on some channelopathies, and to treat according to these results. Okay, we would like to have performed the genetic testing, but in Ecuador, this was GIA 2018, so it wasn't available in our country at that moment. So we refer this patient to the reference center of our city. But what happened there? The patient was implanted with a pacemaker in September 1989. And genetic testing, as already told you, was not available by that date. And this patient died suddenly in June 2020, just in the middle of the pandemic. And due to these pandemic restrictions, necropsy was not performed because it wasn't accepted at that moment. Okay. Well, as you see, it was a very sad situation. It seemed to be an unsolved story, but then another sudden death occurred in this family. But this sudden death didn't occur here in Ecuador. This sudden death occurred in Spain. So the answer finally arrives. And why the answer finally arrives? Because they performed macroscopic necropsy, which showed no relevant findings, but they could do genetic testing. And this genetic testing showed a clearly pathogenic mutation on RIR2 gene, which was related to CPVT. So these findings, these stress tests, these premature ventricular contractions were related not to long QT as we initially thought, but it was related to CPVT. And what's on Island? Okay, when we found these with these findings, we have to make a complete research of this disease in the family. So we make the pedigree and we start testing the other relative of these patients, and we found 7 more cases. And here we have the final results that we arrived to. We performed 45 genetic testing, and we found 16 tests positive for this familiar mutation. 10 of these patients now are under beta blockers. 6 of these patients are using 1C antiarrhythmic drugs, flecainide or propafenone, because here in Ecuador we don't have flecainide, so we use as a substitute propafenone. And 2 of these patients has an ICD implanted. 2 of the other patients refused an ICD implantation. 1 of these patients has a pacemaker implanted. This was done prior to genetic testing because, as you could see, some of these patients has a low heart rate and are wrongly interpreted like sinus node dysfunction, and it was implanted pacemaker. And From this moment, the moment when we arrive to the genetic testing, there has not been new sudden deaths after this genetic approach. So what are the take-home messages? We have 4 messages to take home. First, syncope could be the manifestation of an underlying complex condition. Yeah, not always, and young patient could have a benign condition. We have to explore, we have to make some tests to rule out more complex conditions. It's important to not underestimate symptoms in young patients, okay? Genetic testing could be the key to solve the puzzle. Yeah, if we wouldn't have the possibility to perform genetic tests in this case, probably we could be just imagine among the options we could have for diagnose this case. And finally, genetic approach is extremely important when dealing with sudden death relative, okay? When we have to face this problem with the relative of sudden cardiac death, we have to focus on genetic because this could make our work a little easier, okay? Thank you very much.
Thank you, Dr. Joanne. Very illustrative case. Over to the chairs for their comments. Professor Park.
I think Professor Cabanel is first this time.
Yes, yes.
Please go ahead.
I think something misleading in this patient was the bigeminy, because if we had found at that time a bidirectional VT or a polymorphic VT, the diagnosis would have been very easy, because the patient is a young person with a bidirectional VT or polymorphic VT induced during the exercise, with normal structural heart and normal electrogram. If the case would have been that the case would be simple, but the misleading thing was the bigeminy. Something important is in the catecholaminergic VTs. Usually the electrocardiogram is normal, but sometimes we can find, as in this case, sinus bradycardia, and sometimes prominent U waves. That this is something else.
Dr. Juan, could you please show me the ECG, surface ECG again? I think it is a educational, very important case, but sad case, right? So even though it looks just a sinus bradycardia, but you see this patient shows the left X deviation and the J-wave like fractionation in ABF and even ABL. So if this kind of patient has a strong family history of sudden cardiac death, we have to suspect. And at the basic, the treadmill test and the Holter recording, if we see the frequent PBC, sometimes we induce bidirectional VT during exercise test, then probably it is very important clue to proceed the genetic test. I think, but it is not easy, even in Korea, because from 2 or 3 years before, the government covered the insurance for the genetic test for this kind of patient, but it is very high cost. So it is not common to do the genetic test for the routine practice, but if the patient has a recurrent syncope, family history of sudden cardiac death, I think a genetic test is very, very important and essential this kind of patient.
Thank you.
Something else related to the treatment is the importance of exercise restriction, the use of non-selective beta blockers as nadolol or propranolol, and sometimes it's very important to add flecainide.
Recently, Mayo Clinic published a very interesting paper there. Artificial intelligence ECG can uncover conceal the long QT syndrome or genetic cardiomyopathy. So probably we will have a better diagnostic tool pretty soon, I hope.
Great points, and thank you, Dr. Jain, again for that, Joan, for the great case. In the interest of time, we need to move on to the third presenter. So, Dr. Joan, I'll request you to stop sharing screen, and we invite Dr. Jenny Shroff. He's a postdoctoral fellow at Canberra Heart Rhythm in Australia, and he'll be presenting the next case to us. So unmute yourself, Dr. Janish. Please unmute yourself. Just if you go down to
sorry about that. Good morning, Chairperson, ladies and gentlemen. I'm Janish Shroff. My presentation is about catheter ablation of ventricular arrhythmia originating close to the His location. So this slide demonstrates the PVC registry of our center. Amongst various type of PVCs, we also perform catheter ablation for paralyzing PVCs with good acute and reasonably good long-term outcomes with and without antiarrhythmic drugs. So far, we have done 202 PVC ablations between 2017 and 2023. Out of them, 41 had parahysin PVCs, and we have data for 39 of them with mean follow-up of 46 months. I'll start with a brief anatomy of parahysin region. So as the His bundle traverses the annulus fibrosus and enters the membranous septum, the parahysin region on the right side is just opposite to the right coronary cusp and non-coronary cusp. On the left side, it lies just beneath the right coronary cusp, and His bundle further traverses down, and at the crest of the muscular interventricular septum, it divides into left and right and possibly septal fascicles as well. So there are some ECG characteristics which help us in recognizing parahysin PVCs. Usually they are of narrower complex. Lead 2 is usually more positive than lead 3. Inferior lead discordance can also be seen with lead 2 positive and lead 3 negative. R wave is seen in lead 1. R wave in AVL as well. Precordial transition may help us sometime in recognizing the parahysin PVC, whether they are of the right side or left side, as early transition may be seen in the left side at PVC and the late transition in the right parahysin region PVC. So what are the challenges involved in ablation of this PVC? So as we know, because of the proximity of the conduction system, there is inherent risk of developing heart block. Thick myocardium may be encountered in this region. Often on the right side, it might be protected from the septal leaflet of tricuspid valve. On the left side, aortic valve leaflet may make it difficult for us to reach the left parahysin region. Sometimes it may have variable exit as well. So now that we know the challenges, how to perform a successful PVC ablation in this region. So there are many pieces to this puzzle. Starts with pre-procedural care, ECG, 12-lead Holter to know the morphology and the burden of the PVC. A stress test may be performed to know the exercise tolerance, what happens to PVC on exercise, echocardiogram to look for the structure and the LV function, CT to know cardiac anatomy, CT coronary and coronary anatomy, MRI to look for scar in the target location. We always use a real-time imaging with ICE. We use CARTO sound with sound star catheter, and 3D mapping is essential, especially mapping of the basal septum, membranous septum region, the cusp and RVOT and adjacent RA region is very important to create a His cloud there. Then we always perform an activation map, extensive activation map on both the sides to locate the PVC, and then we use pace map as a complementary tool. We always use a force sensing catheter for ablation, and if risk of heart block is quite high, then sometimes cryoablation may be used. So now that we know the challenges involved, I will demonstrate a few cases that we did, which probably will highlight the challenges we just discussed. So our first case was 68-year-old male with asthma. He had bradycardia notification from his smartwatch, was referred to us for arrhythmia management, and Holter showed 24% PVC burden. A 12-lead Holter was done, and the clinical PVC was the most dominant one with 93% frequency, and EF was 45%. His coronaries were normal. There was no scar on MRI. We took him for ablation as he was not tolerating antiarrhythmic drug also. We did extensive mapping of the PVC and found it to be the earliest activation was found to be on the right parazine region. It was 37 millisecond early. On the left, it was not early. As we can see, there was excellent pace map also in the right parazine region. We did ablation in this region. What we did this time is we intubated him and did the ablation in apnea. So I'll play this. So it's very important in such cases that it might be discussed with cardiac anesthetist beforehand so that things are ready during ablation. And because of the apnea, the movement was minimal. I will show the final lesion set here. So with limited ablation, the PVC was eliminated. On 12-month follow-up, he was free from antiarrhythmic drug. His ejection fraction improved to 60%. His PVC burden was just 3%. His quality of life improved greatly. Our second case, a 54-year-old male with hypertension. He had palpitation, was filling skip beats. Holter was done, 25% PVC burden was seen. A 12-lead Holter showed it was monomorphic. Echo showed that he had low normal ejection fraction, 52%. Stress test was almost impossible. He could only go for 3 minutes. He had severe exercise intolerance. He developed NSVT on exertion. Coronaries were normal. MRI showed a small scar in the mid-inferior septum and mild LV dilatation and global hypokinesia with ejection fraction 50% on MRI. We offered him ablation. As we can see, he was spontaneously throwing PVCs at the start of the procedure. Bigeminy was seen. We did extensive mapping of his PVC again on the right as well as the left side. This is the activation map in the right parazine region. As we can see, the activation was earliest activation was found to be in the right infrarazine region. It was 20 millisecond early there, and then we did ablation there. It's very important that that the tools we use during the ablation, a steerable sheath, force sensing catheter, the stability of the catheter becomes very important, as and the planning is also important. As you can see at the end of the ablation in the right video, at the end of the ablation, when the catheter moves, it moves away from the his location rather than towards the his location. After ablation, he was free from PVC without any antiarrhythmic drug at 12 months. His ejection fraction marginally improved to 55%. Main thing, his exercise tolerance greatly improved. Now he could go for 12 minutes on stress test, no NSVT, and his quality of life was significantly improved. A third case, 66-year-old male with a hypertension, history of ischemic heart disease and stenting of ramus. He had symptoms of palpitation, shortness of breath last year. His Holter showed 23% PVC burden and runs of NSVT. His 12-lead Holter showed that the PVC was monomorphic. Ejection fraction was 55%. Mild LVH was seen on echo. Again, he had effort intolerance, 6 meds. He could go on a stress test. CT was done. Stents were patterned. Cardiac MRI was done. LG was seen in the basal mid-inferior septum. Ejection fraction was 52% on MRI. We offered him ablation, and this time around we created activation map on the right as well as the left side. The earliest activation was found to be in the left parazine region. As we can see, there was a sharp pre-QRS potential seen in this region. Excellent pace map was seen with all 12 by 12 and 99% pace match. After this, we ablated in this region, and we always look for acceleration or suppression of the PVC in initial few seconds, and if that does not occur, we stop ablation. Uh, Otherwise, we may sometimes, if it occurs, then we may go on and deliver 60-second lesions usually there. And with very limited ablation, his PVC was eliminated. This is the spinal lesion set in the right image there. So in early follow-up at 6 weeks, he's doing well. He's free from PVC, no antiarrhythmic drugs. So in conclusion, ladies and gentlemen, Mr. Chairman, ventricular arrhythmia from this parahesian region, they display distinctive ECG characteristics which aid in recognition and mapping during the ablation. And catheter ablation is usually performed safely and effectively, which improves LV function, improves their quality of life, and possibly offers freedom from the antiarrhythmic drug also.
Thank you, Dr. Janish. Again, a great case. Professor Park, your comments on this?
Yeah, Dr. Shroff, the excellent cases, and I was surprised how come you ablate the parahesian PVC, all three cases successfully without any complication. So I have some questions. When you ablate the PVC location, did you see there's the far field his potential or not? And how much power did you start? Because if you review the PVC ECGs, all three cases has a different QRS morphology.
Yes.
Which means the exit side of this PVC could be away from the his bundle. So when I do the PVC ablation, I always try to map completely with patients, right side, left side, transaortic, transeptal. If the patient has some structural heart disease, I strongly recommend to use microcatheter and map their septal perforated veins. So did you see any far field his potential?
Yes. So we always do extensive activation map, and we try, if it is quite near to his potential, with large his potential, we try to be as far as possible of the his bundle with usually a low his potential of 0.2 millivolts, and where the AV ratio is also less than 1. So in this region, we usually do the ablation, and that has actually been successful so far. The complication rate has been low. We had one complication where patient developed complete heart block, but because he had conduction system disease and LV dysfunction, he already had a CRT in situ, and so which did not affect the outcome. But yeah, and in one case we have faced with the RBBB, but fortunately on 6 months follow we saw that RBBB recovered. So yes.
And your power settings?
Yeah, the power setting, we usually our standard power setting is 35 volts. But if we see that the risk of heart block is quite high, we sometimes start at 20 watts. And if the suppression is achieved in initial few seconds, 10 to 15 seconds, then we gradually increase power to again 35 watts and go up to 60 seconds. That is our usual lesion length, the duration of the lesion.
Dr. Nestor, Professor Cabanillas?
I want to congratulate the colleague, and just to remark some very important things in the parahesian ventricular arrhythmias. That is very important to look for the precise site at the right ventricular septum, the left ventricular septum, also the right and non coronary cusps, and also to keep in mind the possibility to map the right atrium, because sometimes it's necessary to map the posterior superior process. And then in this fourth zone, we have to base the all our approach. And also some tips like the apnea, and also to stop the irrigation. And when we start ablating, it's very important to stop when we get junctionals, AV block, or prolongation of the AH interval, or we get a right bundle branch block. This is some concept to remark.
Thank you very much, Dr. Cabanillas. I think some great learning points from this case as well. I think the use of apnea is also well taken. I've heard it used in some other situations also, like ablating the ridge in AF ablation, for example. So great case, Dr. Janish. Thank you very much. We'll move on to the last presentation today. Dr. Sergio Diaz Tostado, a cardiac electrophysiologist from the American British Cowdray Medical Center in Mexico City. He's also the co-chair of the Young EP Committee of the LAHRS. So we'll hear from him now on extraventricular PVC ablation. Dr. Sergio.
Hello, everybody, and thanks for the invitation. Dr. Kumar, thank you very much. And Dr. Janish, great maps. Those are beautiful images. And we're going to join a little bit what you said and a little bit of this case, so we can have something like in between, like in a hybrid learning. So this is going to be just a case. It's a 56-year-old female. She's a teacher. History: her mother has Sjogren's disease and her father had end-stage renal disease. No further investigation about this comorbidity or the history. So in 2010, she had a hysterectomy, and during the hysterectomy, she had PVC. So they were noted with an anesthesiologist. They were recorded. The surgery continued without complications, and cardiology saw the patient in the post-op. And they did an echocardiogram at that moment, and then she was discharged 2 days later. She was asymptomatic and no follow-up appointments were done or scheduled by cardiology. And then in 2022, she started having shortness of breath. So she saw when she was swimming that she had more trouble catching her breath. And the main reason she had seen by a doctor to do an appointment with cardiology is that she compared herself with other 56-year-olds, and she noted that she was like could not keep the pace while walking or swimming or doing anything else. So, well, of course, this is not her, but the echocardiogram showed a normal EF, 52, no alterations in the wall movement. The volumes were okay, no problems with diastolic function, and just a mild mitral valve problem. Holter. They did a Holter, they said sinus, no ACEs, and the PVCs. They saw 27% of monomorphic pairs triplets bigeminy and trigeminy, no BT in the Holter. They did blood tests. If you do not use these scales, though, all the bloods were normal. So cardiologists saw the patient with all these studies and then referred with EP for PVC evaluation. This is the EKG. We're going to go a little bit further. So just make note how is the morphology or the axis. And we're going to discuss a little bit this morphology. We're going to take some details about that. So you may saw it was like a little bit of a left bundle morphology where the D2 was isoelectric, ABF was negative, DC was negative. So we were like more or less looking to the base, a little bit to the septum, mid-septum of the RV. And for the EP evaluation, as we saw the patient had a worsening functional status. The PVCs were 27%. It was an accessible area for ablation. The PVC ablation was indicated. And if we see this table, we can see the patients with PVC that were no RVLT or fascicular, and even though the echo was normal, the patient had change in the functional class, so it was an ablation class 1 indication. The setup, I used the cardo, zero fluoro. I did 2 punctures, one to use the eyes, and the other one to put out the BCGO first one, once the pentaarray would ID the map, and then exchange for a smart touch DEF. My initial parameters were 30 watts or 120 seconds. So first, I'm just gonna give you a little bit of this ICE image because we went straight to the RV, straight to look for the PVCs, and I'm gonna show you later the 3D map because I don't wanna ruin the case. So we started mapping. We located a premature area and the right posterior septum. We ablated. We stopped the PVC for about 5 seconds. Then the PVC returned and we started giving ablations around the area. After a couple of new ablations, we stopped and looked again to the morphology. And this is what happened. Look very closely to V1, look the morphology in V2, we'll be notching V3 AVL, and look also the transition, the PVC, the first morphology, we got it like around B4, and then check on the second morphology. It has a little bit of slight changes. So V2 change, instead of being like positive, negative, it went fully positive. Then AVL, look a little bit, there's a notch that disappeared in AVL. The transition went earlier to V2. So with this change of morphology, we said, okay, let's see what happened. So V2 went a little bit positive, and then the transition went earlier. So we start mapping again, and we started mapping without having a very good premature or early activation. So what's next? The PVC parent changed. No PVC suppression was achieved while ablating in the surrounding tissue, and all mapping was on time. Nothing was early. So next question was ablate with more power, the same spot but just higher power, or do another LV map, but retrograde axis. We were already like around the septum and the base of the right ventricle, so maybe let's go to the left ventricle. Do another map with a transmitral valve axis. Do epicardial axis. I didn't want to do epicardial, so I first thought of going to retrograde and see what was happening in the cusp. But with my colleague, I was doing the procedure. He suggested, let's do an LV map on the right atrium. Let's give it one shot. It's only one shot, just one shot. Let's map from there. And then this is what happened. We started mapping in the right atrium, and we found a very early area, earlier area than compared to the right ventricle, and we ablated there. We went to the right atrium and we ablated there. Look at this image video from the ICE. This is a successful point where we ablated and the PVC was suppressed in less than 1 second. This area is the right atrium. You can see here the aortic groups, and this area is the left ventricle. So look where we are. I'm gonna go show you again the 3D map. Look, we're looking here. This is the superior vena cava, inferior vena cava, and this is the area where we're mapping, like posterior to the septum. Look to this, the map in the right. You can see this PA view. We are pointing towards the septum, like in the posterior area of the septum, in the right atrium. And success. No more PVCs in this patient. And so post-ablation follow-up, no PVC. The functional status changed to NYHA1, no shortness of breath during exercise, and was sent back to cardiology for follow-up. So just a little bit of information about this. Remember, the anatomic relationship between the right atrium and the left ventricle. Look at the posterior superior process of the left ventricle. So look at the communication, look how the vicinity, look how close they are, the right atrium to the left ventricle. So that's why we could get the PVC from the right atrium. This is the membranous area of the septum, of the ventricular septum. As you can see here with the light transluminous, it's very, very thin. That's why we can get through there. When you have a congenital defect, well, could be also done by medical procedures, but most of the time they're congenital. It's called a gerbil defect. You can see here with the CT scan with contrast, path of contrast between the left ventricle and the right atrium. Look also over here, you can see the defect communicating RA and LV. And I want to show you two more slides. This one is a very important look. We were ablating over here. I'm going to put on the next slide the two images all together, but look how close you can be. Remember also, if you have a morphology, you can think it's coming from the base, cusp, maybe in the base of the left atrium. Also, you can ablate from the aortic root. Don't forget about this area. And you can see here, head to head. I tilted a little bit the images so we can be like the same cut. And here you can see the catheter, the aortic root, and if we can see the anatomic piece, the catheter was around this area, and we can get that PVC. Take-home messages. Also, remember, patients would say with PVCs, a big burden of PVCs, that they are symptomatic. Like, try to never trust them because sometimes they don't feel the shortness of breath and they are already having some changes in the functional status. If you're going to go to ablate PVCs or BT, always use eyes and 3D mapping. And if you don't get it, you don't have a very good early signal, don't forget the anatomic neighbors: cusp, coronary sinus, posterior superior LV. Thank you very much.
Thank you, Dr. Sergio. Again, a wonderful anatomic illustration of the importance of the RA-LV relationship. Dr. Cabanillas, your comments?
No, just to remark the importance of the possibility of that we have to ablate ventricular arrhythmia from the right atrium. Also, when we consider we finish the ablation, it's very important to do birth spacing from the atrium and ventricular, and to do some challenge like isoprel or isoproterenol challenge at the end of the procedure, just to know if we really get success.
Professor Park?
Oh yeah, beautiful case. Actually, the professor, the Santangeli, he provided us a very, very useful anatomical access site, and I have several experience of posterior superior process ablation, and I was impressed that you showed us such kind of beautiful ice map. I don't know how did you make it such the detailed anatomy showing by ice. My comment is that you show the two different kind of PVC morphology in ECG. First one, I do not believe we can eliminate that PVC from the posterior superior process because the precordial transition is V3-4. It is two mid to apical side. However, the PVC number 2 is perfect site because the transition is early transition shows a very basal site. And another point is in the carton map, in the ablation local signal, the V signal is too big. In my experience, when I successfully ablated the posterior superior process, it is only far field V, small far field V, but the A signal was much bigger. So I wondered your catheter position is just between the LV and the RB and the RA annulus area. So that is my comment.
Yeah.
Yeah, that's right. Also, the pattern, the second PVC pattern. I saw some reviews that Dr. Pascale also had some with Dr. Garcia, Fermin Garcia had some publications, and the second morphology, as you said, is like the typical one.
Yeah. And the catheter is because there is no the leveraging point of your ablation catheter. Sometimes catheter slip into CSOs and coming back to right atrial, the posterior superior process. So when the successful ablate the posterior superior process ablation, I make a catheter like this, not straight and make a deep curve and make a bigger, better contact. And if you use the deflectable sheaths, that might be the best.
Yeah, I used the BCO there, so we have a very good stability.
So how did you
visualize? First of going to the right ventricle, and then we have to pull back to the RA. Let's see if we could catch it.
How did you visualize this posterior superior process by IC images so beautifully?
I try to remember. I tend to recall, and I remember very clearly that we were always in the RV. I think this view is from the RV, tilting a little bit like anterior, so we can see a little bit higher. If I recall.
Thank you.
Great comments from the chairs. And any other comments or queries pertaining to any of the cases? I see that there are no other newer questions in the chat box. So the chairs have any other comments regarding to any of the other cases? If not, I think we have just slightly over time. So I think we should go ahead and close. I would really like to again extend my sincere thanks and appreciation, first of all, to LAHRS for joining in this activity. And we are very happy to have done this joint APHRS-LAHRS Young EP webinar. And I hope we will do more joint activities in the future, with also the support of our respective presidents from APHRS and LAHRS. It's very nice to get their support. I would like to thank all the speakers. They have put in a lot of effort and they have given us wonderful cases. Within the short time, it was a challenge, but all of them have done very well. And I think we got excellent learning points. And thanks to our chairs, Professor Park, Dr. Cabanilas, for their valuable comments. I hope everyone got a good learning experience from this, and we look forward to more programs like this in the future. So thank you, everyone.
Thank you. Bye-bye.
Thank you very much.
Thank you, and have a great day. Thank you.
Thank you very much.
Thank you.